first paper of this session, which is the chemotherapy for patients with EGFR Mutated NSCLC who has progressed on EGFR-TKI. It is an exploration of unselected treatment in multicenter real-world cohort study. So coming to the background, EGFR Mutated Advanced NSCLC, for past decade, the EGFR-TKI has been in first line, and with the favorable EFS survival and the impressive tolerance of osimertinib, it has taken front seat in the treatment of the EGFR mutated NSCLC. However, all tumors eventually develop resistance to EGFR-TKI, and this resistance pattern in most of the patients will be of the alternative pathways, or it can be the different mutation in the EGFR. In the subsequent line of treatment, there has been emerging data which is coming up in past 2-3 years regarding biomarker-driven targeted therapy after TKI failure. However, till now, post-TKI failure, chemotherapy remains a standard option, and it is being practiced in most of the patients. So this study addressed which systemic treatment is most appropriate post-EGFR-TKI progression, and what is the real-world efficacy of these common chemotherapy regimens, and is there any role of adding anything beyond platinum doublet in this setting, particularly anti-angiogenic agent and immunotherapy. So this was a multicentric retrospective cohort study which was done in 2 sites at the Netherlands, and they included a patient which were treated between January 2015 to July 2021, and they included advanced non-small cell lung cancer patients who had EGFR mutation. Majority of them had the exon 19 deletion and L858R mutation, post EGFR-TKI progression, and who had received chemotherapy either with Chemotherapy or paclitaxel. Primary outcome was progression-free survival in first-line chemotherapy, and secondary outcomes were PFS in entire cohort, overall survival, and response. They defined durable benefit as a PFS of more than or equal to 6 months. They included 135 patients. Majority of them had received osimertinib, 71% of those. Majority of them received that in second-line setting. Total 171 lines of chemotherapy were given in these 135 patients. 33 patients received more than 1 line of chemotherapy. So they had a first-line cohort of 106 patients. Around 4 years was the median follow-up in this first-line cohort. So they used these 4 regimens. The most common regimen which was used in the first-line cohort was the platinum and paclitaxel, which was combined with either cisplatin or carboplatin. The next second common regimen in the first-line cohort was the ABCP, using atezolizumab, bevacizumab, carboplatin, paclitaxel. While the most common regimen in the second-line setting was the paclitaxel and bevacizumab, in which they used the paclitaxel in weekly dosing with the biweekly bevacizumab, while a small number of patients received paclitaxel and bevacizumab. So coming to the characteristics of the patients, median age was 63 years. Majority of them were female. Majority of them had a good PS. 0 to 1 was in around 80% of the patients, except the paclitaxel and bevacizumab. Majority of them had the sensitizing EGFR mutation. 2/3 of them had concomitant TP53 mutation. So the majority of them received 4 cycles of chemotherapy, though in the ABCP group they received a median of 8 cycles. The treatment discontinuation due to toxicity was present only in 20% of the patient, though it was slightly higher in those patients who received paclitaxel and bevacizumab, probably as these were the patients who received second line of treatment. And around 40 to 50% of the patients required some modification during the treatment. However, despite all this, majority of them received subsequent line of the treatment also. I mean, the PFS in the first line cohort after this chemotherapy regimen, the median PFS was 5.4 months. It didn't differ between the chemotherapy regimen, though the numbers were less. It didn't differ between different EGFR mutation, and didn't differ as per the TP53 mutation status. 40% of the patients derived durable benefit, that was more than 6 months of PFS with this treatment. Though this durable benefit was seen particularly in those patients who didn't have CNS metastasis. This is the regimen-wise PFS. It was almost 5 to 6 months. The larger cohort of the paclitaxel platinum and ABCP group. In the second line, the median PFS was higher in the, it was 5 months in the paclitaxel and rosuzumab, while the ABCP and paclitaxel and platinum, these were driven by the mostly first line treatment, because majority of them received this treatment in the first line. OS of the first line cohort, the median OS was 15 months, and as we see this graph, the median OS didn't differ among the regimen. Among the regimens in which the number was substantial, the median OS was 15.4 months in paclitaxel and platinum, while it was 11 months in ABCP2. So if we see the tumor response, the highest response was with the combination of chemotherapy with some targeted agent, almost 70% response in the ABCP group, with 3% of patients achieving CR. Disease control rate was similar among these groups. This was some of the other retrospective studies in which there are two which we have highlighted. These are slightly contrasting. The first one showed no benefit of combining immunotherapy as compared to angiogenesis inhibitor. The other one showed the benefit of combining immunotherapy. Coming to the study only, it shows that the platinum-based chemotherapy after the EGFR-TKI failure provides clinically meaningful PFS and OS benefit with a tolerable safety profile. While in the second line, paclitaxel provides a reasonable tolerance with a median PFS of 4.9 months. Though the combination of angiogenesis or immunotherapy in the current analysis, it provides a better response with numerically better PFS. However, as in the EMPOWER 150, the experiments also showed the OS was not statistically significant, though it was numerically better. In the Indian context, the accessibility of immunotherapy is less, osimertinib may not be feasible due to substantial financial burden. Fit patients may receive the JAK plus chemotherapy. So this this data gives us the confidence that chemotherapy after this TKI failures is feasible and can be safely delivered in our setting also. Thank you.